So it's a real pleasure to be with you all. I'm so sorry I can't be with you all in person. I have been there at, I think, two power conferences in the past. I know for sure one, but it's just really nice to be connected with you all. And I have some questions in here, so I'm hoping you'll be able to um, chat in or not. Hopefully that will work out just fine. But I'm going to go over safe use of intermittent auscultation to expand freedom of movement in labor, which goes very nicely with one of your key initiatives right now. So at the end of this presentation, I hope you'll be able to describe why to perform intermittent auscultation instead of continuous fetal electronic monitoring as being the only option that we offer, and that you'll be able to discuss how to perform intermittent auscultation. So I'm going to be going over these topics in our presentation today. So first, I want to share with you that our mission is to expand the use of improvement science to eliminate preventable perinatal morbidity and mortality and end racial and ethnic perinatal disparities. So this work is very critical for all of us. Oops, went backwards accidentally. IA is, as I said, is a critical skill that is needed to be proficient and perform for all labor room nurses. I feel very strongly that this is one of those skills that we stopped practicing. We lost the ability to perform, and there's a lot of reasons why we should be performing IA, and we won't be proficient if we don't have education and if we don't practice. And so these are some of the situations like power outages, disasters, evidence-based. It's just evidence-based for low-risk patients. It's also recommended by all professional organizations. And it's always been a part of A1's fetal monitoring course. And it's a standard of care for fetal assessment during low-risk labor and birth. So if you don't know how to perform IA, it is something I feel very strongly that every labor room nurse and doctor needs to become proficient in. So researchers, meant well when coming up with the continuous electronic fetal monitor, which was actually pretty new at the time when I started. I have learned every white hair. I'll just say that over the years. And the idea was, let's try to predict acidosis, fetal acidosis. So that way, maybe we'll have better fetal outcomes when the infants are born. We'll have better infant outcomes. And so their intentions were really well-meaning. And but what have we learned? Like, I'll just ask that question right up front. Has that vision of this machine that we spent so much money on and so many legal costs and so much time on, has it helped us really? I mean, no, we haven't. It hasn't helped us detect or prevent poor outcomes. So it hasn't met what we wanted it to do. I'm not saying it doesn't have a place in a modern labor room floor. In fact, that is where, if a high-risk patient situation, you do want to have ongoing continuous fetal monitoring. But what we have lost is we've lost people losing the confidence to say, I can monitor low-risk patients and actually interrupt what sometimes becomes this cascade effect. And I'll go over that in just a minute. But and so by not offering intermittent auscultation and relying so heavily on continuous electronic fetal monitoring, we have limited a laboring person's ability to move around in labor. It's had this unintentional consequence, which actually has led to some negative outcomes for our patients. So that's important to recognize, This is not just a good thing to know. It's actually very important part of our toolkit, part of our skill set. So let me go through a little bit of the evidence. I'm going to summarize the Cochrane Systematic Review, which had included 13 trials. And these trials had included over 37,000 participants in 7 countries. Now, they weren't all, frankly, the best designed studies. So I just want to be clear about that. They were from 1976 to 2006. Most of the trials did have one-on-one care. So when we're talking about one-to-one nursing care in labor, that really, in my opinion, should be the standard. Women deserve that level of support from nurses in our country. We're a very rich country. And so in most of these studies, most of the trials did have one-to-one nursing care. So let's just be clear about that. It also was at a time when our C-section rates were lower. So, and they also included low risk, high risk, and mixed risk populations in their studies. And this is just a quick summary of this, all of the systematic review, which showed us that there is no difference between IA and continuous electronic fetal monitoring in predicting metabolic acidosis, preventing perinatal death, preventing cerebral palsy, reducing NICU admissions, and even in with APGARs less than 7 at 5 minutes, APGARs less than 4 at 5 minutes. So also in reducing the use of analgesia and also in reducing the use of oxytocin augmentation. But it did show us that there were IA did decrease C-sections for fetal indications, decreased instrumentation of vaginal birth for fetal indications, and increased spontaneous vaginal birth. The only possible benefit of continuous electronic fetal monitoring, which is very, very limited, and probably, frankly, given all of the benefits that we would be, like the amount of benefit does not outweigh the risk of keeping people in bed, was that there was one fewer case per 667 continuously electronic fetal monitored patients there was some decrease in neonatal seizures, which was not necessarily related to long-term outcomes. So as I already pointed out, related to cerebral palsy, etc. So the evidence is clear that IA should be part of our skill set. There's no doubt about it. And in fact, any of us, like myself, I've been a long time used continuous electronic fetal monitoring myself for many, many years. I've stood there and argued and discussed like how to interpret fetal heart rate tracings, even with annual educational sessions, everybody getting educated together. There's just often disagreements, not only how to interpret, which that interpretation affects how we respond. So we're fooling ourselves if we think that continuous electronic fetal monitoring is bringing us better outcomes. And just to be clear, that the use of IA has been identified to be evidence-based. It's totally legally able to be supported if there is a bad outcome. You have more support for the fact that you used IA than you would by not using it. And we have 3 major professional organizations who have strong position statements around the importance of providing IA. So you don't have to just take my word for it today. I'll tell you, like, I'm just like, here to just help promote it. That's one of my new missions in life, is to help get IA skills among all of the nurses and doctors that take care of patients. It's just what we used to know needs to come back. So we need to bring it back. And that's one reason I was so excited when Don asked me to talk. I was like, yes, I definitely am excited to help Arkansas bring this skill to all of the labor room nurses and doctors. So just to recap, we have the evidence that shows that continuous electronic fetal monitoring contributes to high cesarean rates via two possible mechanisms. One is that it's a low predictive value, meaning that operative deliveries for false alarms, or it reduces, and it could also reduce mobility and autonomy, setting up a cascade of interventions that end in a C-section. So I'll show that also with this slide. If you see like continuous electronic fetal monitoring at the top leads to reduced mobility, which leads to increased pain, which leads to slow labor progress, which leads to interventions to speed up labor. So that's really, whoops, sorry. That's really important for us to understand that. Now we can also draw arrows that from reduced mobility to interventions to speed up labor, to slow labor progress, and to increase pain. So just it's not without its there's a lot of benefits to having an IA and have freedom of movement. So look at this picture that shows the person in bed with these short cords. I think we also should do more, if we're going to do continuous electronic fetal monitoring, I think we should do more telemetry monitoring, actually. And this is not an unusual image to see someone with, she just got a fetal heart monitor on and a contraction monitor on, an IV. And it just shows, though, not a very, not easy to move around in labor, hard to do the spinning babies and other things. Compared to this image where the patient has much more freedom of movement and also can have hydrotherapy. So it just gives women more options. We have done some PQI profile. This goes back in 2019, so this is not new news. That I'm telling you something you probably already know. But Beth Stevens Hennessy out in California, their hospital was working to reduce C-section rates. And this was her quote, that you are considered a healthy, low-risk mom. We don't need to monitor you continuously. Actually, that increases your risk of a C-section. And so they work to have all of their low-risk patients have intermittent auscultation, labor lounges where they could walk around, and also other ways to support women in those early phases of labor. Because of the dominance of the electronic fetal monitoring, we have a workforce that is not skilled in how to perform IA. And if I was in the room with you all, I would have you raise your hands. But I bet these data are very consistent in Arkansas, but this is from Amy Romano, and she showed that previous direct experience with IA in school and training was very limited for nurses and midwives. And she didn't have a nurse sample doctors, but I know from other projects I've done that the doctors will be like, yeah, I've never really done it. And it's hard if we don't have mentors to help us learn how to do something. It's hard to make that change. We totally get that. And also it's not the kind of, it is a skill. It's something that takes practice. So at the Institute for Perinatal Quality Improvement, we launched the intermittent auscultation course. We have now over almost 3,400 learners who have taken this course, and people internationally, and in pretty much every state in the United States have taken this course. So we've got a lot of feedback from this course, and it's very positive, and it helps people gain the skill and knowledge. It's not the only way. It's a beginner. It's a beginning step towards moving into more IA. So from those 3,379 learners, we ask questions about what their background is. And most of the people who are taking our course are nursing students. nurses, and then midwives. So, and then the majority of the settings of the people taking the course are in hospital settings. So there are a lot of people interested, and right now I think it's again making something that was old new again, and also realizing, wow, this is one way we need to approach the crisis and the maternal morbidity and mortality crisis. It's not all about hemorrhage protocols, which frankly, you all know that I helped put together a lot of that hemorrhage work and other hypertension protocols. I've done a lot of work on that. It's not instead of those are still needed. But if that's all we pay attention to are the high risk pregnancies, we're missing a whole bunch of ways to prevent people. It's like if we're standing on top of the hill and we throw people in the water and then we wait at the bottom, we rescue them. We think, oh, that's so great of us. Look what we just did. But we need to stop throwing people into the river. So it's more upstream, this preventive work that we need to do. But if you haven't had much experience with IA, and that's what this slide shows, if you lack prior experience with IA, I totally get, like, as a labor room nurse, is like, I don't want one more thing to do. But on the other hand, part of our job is to provide evidence-based care. So this is one evidence-based care component that we also need to embrace and approach it. I saw a little bit of Dawn's presentation, and one of those skills that needs to be part of the skills practice sessions that you're doing, and just having more mentors in helping learn this. So this just shows that most of the learners who took the IA course that we offer, most of them disagreed or strongly disagreed about having substantial experience performing IA. They just didn't, and some of them neither agree or disagree, but if you add that all up together, they're not feeling very confident of their IA skills. So, but of course they were coming to learn. So if you're not feeling confident of your IA skills, you're in, there's other people with you. So, and when we don't know something, it's time to admit it and then go to learn it. But again, it's an essential that we all provide laboring patients with the options that support freedom of movement in labor and that help with spinning babies, ways to monitor the patients during any of those, any of those types of support. Now I'm going to just go through really quickly. It's not meant to replace other kinds of education, but let's just go through some key things about how to perform IA safely. So you want to make sure that you're using IA on people who are eligible, and you'll need a hospital policy for that. But it would be how low-risk patients are defined, and I would refer back to the ACOG A1 and ACNM definitions. I do want to be very clear, though, because this is research-based practice that I promote, is that the research shows that it has been used in high-risk populations, preterm births, and even with people on oxytocin. I am not proposing that. I'm just saying that if you were really skilled in practice, we have to acknowledge that the studies show that that's also still acceptable. So just to be clear about that, everyone does agree that it is the preference for a low risk birth and labor, that IA should be the default, not the afterthought. It should be predominant method of fetal monitoring. One of the ways you determine eligibility is to do a 20-minute admission baseline strip, which is pretty standard, and so that should be part of your IA policy. So again, just want to point out that whether IA is used in low, mixed, or high-risk groups. Whether continuous electronic fetal monitoring was been used in low, mixed, or high-risk groups, it's not been shown to be clinically significant benefits. So this little diagram just shows that IA consensus is that the benefits outweigh any potential concerns over continuous electronic fetal monitoring for sure in the low risk population, but there may be some benefits in other populations as well. So that would be your organization to decide those categories. The equipment you need a listening device, and recommend it be something that could, so you could perform IA during hydrotherapy. There's our two examples on the screen. If you're using a Doppler, you need Doppler gel, you need extra Doppler batteries, and or you can use a fetoscope. You can use a clock or a watch with a second hand. And then it is important that you have maternal pulse oximetry available. If the mother's pulse is elevated, which you want to check why that's happening, you don't want to just ignore that. But if the maternal pulse and the fetal pulse are very similar to each other, you may want to do some continuous maternal pulse oximetry to help distinguish which is fetal, which is maternal, and just to confirm that. You wouldn't normally do both continuously over any length of time. It would just be used as an assessment tool. I also want to be clear that A1 does, in their position statement, in their principles and practice books, does say very clearly that they do not recommend that you use a continuous electronic fetal monitoring with a strip as your tool for IA. And I'll just read this. It says, though these brief and intermittent segments of EFM data may be retrievable, these data generated would be of too short duration to be reliably interpreted. So it could be held against you, like in a legal case, perhaps. And to minimize, and so somebody might overinterpret that or think something, read between the lines. So to minimize this potential issue, using a handheld Doppler or fetoscope may be preferred. These issues should be addressed by institutional policies and procedures and by documenting the method of fetal monitoring utilized. So frequency, you want to do latent or early, active, and second stage are different frequencies. Early labor, latent labor is 1 to 2 hours when they're admitted. Active labor is every 15 to 30 minutes, and second stage is every 5 to 15. And so you want to increase these frequency when there is a concern. Now, just to be clear, if you are doing continuous electronic fetal monitoring, you do need to assess that fetal heart rate at frequencies as well. So although, and again, at the beginning, I said I really feel strongly that all women deserve one-to-one care in labor. But that has been a barrier to adoption. And so you want to just be cognizant of that. So then another component, well, let me just back up and say one more thing about that. So too often we think that the electronic fetal monitoring, the continuous electronic fetal monitoring out at the desk, and more eyes on it might be safer for the patient. But we just want to be clear that that has a lot of other potential downsides for the patients. So you just have to weigh everything, and the needs of the patient should come first. So when you're assessing baseline, how you do that with IA is you assess the baseline during prenatal care. So you would determine, before labor, hopefully you get the records, the prenatal records, and hopefully someone has noted what the baseline would be. When the person is in labor, then during the initial 20 minutes assessment, You also can determine baseline during that 20-minute admission tracing. And then also, when you're performing IA assessments, you want to be periodically assessing baseline as well. And I'll go over how to do that in just a minute. And if you have any change in the patient's conditions, such as rupture of membranes or the presence of a new risk factor, then that's also when you would reassess baseline. I think actually, even with continuous electronic fetal monitoring, that we often are not as clued in to what that baseline is and how that might be changing. So I think it's no different for IA than for continuous electronic fetal monitoring. Both of them, you need to be really careful about knowing what the baseline is. It affects whether it's an acceleration or a deceleration. Now, there's a new consensus guidelines coming out where the fetal baseline was originally, and it's still in the A1 literature, recommended a 30 to 40 second assessment period. But the community birth midwives and others in the nation, including A1 representatives and leaders from the national office, participate in this consensus document. And they have decided that 30 to 40 seconds for baseline is just not really adequate to really assess a baseline. And if you're looking on, if you're doing it with continuous electronic fetal monitoring, we know that it's usually like this 10-minute period, right, that you're assessing baseline. So the same principle would apply. In this case, however, you're going to be listening for 2 minutes, not necessarily consecutive 2 minutes, within the same 10-minute period, just to get a sense in this to do that, what the baseline is, and then average the counts to determine a single number of beats. And I'll have, look at that a little bit. So you don't want to determine baseline, just like with continuous electronic fetal monitoring, during fetal movement or during contractions. And again, you don't include any of those in the calculation of the baseline rate. The normal baseline is 110 to 160 beats per minute. Accelerations and decelerations are defined the same with IA and continuous electronic fetal monitoring. So yay, that makes that easier. And it's changes from baseline lasting at least 15 seconds, but less than 2 minutes, with the peak or the nadir at 15 beats per minute, different from the baseline. And you should always know or reassess baseline when interpreting accelerations or decelerations, and write down each consecutive auscultated interval or have another team member transcribe. So when do you listen for accelerations and decelerations? Again, you want to do that between contractions when assessing baseline, during a contraction, and at least for 30 seconds after a contraction. So you want to do essentially, it's before, during, and after a contraction, right? So it's between, during, and after a contraction. When you hear a deceleration, you need to measure and document the maternal heart rate. So you make sure you're not picking up the heart rate, the mother's heart rate, or getting confused. So you want to confirm that indeed it is a deceleration. All right, so this is a case example. We're using the 6-second count. So the baseline has been 120 on previous assessments. And Don, I know you're in the room with everybody. So if you all would just look at this, these are the 6-second counts. So just to remind you, if you are doing 6 seconds, 12 would be times 10 is 120. So if you count 12, then you times it by 10. And so it's 120. Here, I'll just do another click. So it's be 120, 120, 130, 140, 130, 130, 120. So I'm just wondering if anyone's brave, and I don't know if you can put in chat for me, if I can see in chat those that are online electronically, or if Don can chat in. But would you document that there's been an increase or a decrease? First off, has there been an acceleration? Does it meet the definition of an acceleration? And yes, it does. Anybody disagree with that? Let me see if chat comes in. Nobody's even chatting to me. This is really hard. So I feel like I'm just talking to myself though. So anyway, yeah, so go ahead.
So we're in the audience, so we don't have the chat capability, but we hear you loud and clear. And
yeah.
So we'll try to use our microphones to answer your questions if we can.
Oh, that's okay. So did everybody see that this is a acceleration? Anyone disagree? Don, can you tell me?
I'd say acceleration.
Yeah, so everybody agrees. Okay. Yeah, so that's how easy it is. It's really not that hard. The biggest thing is just people trusting their counting. And there are other methods. People could count for 30 seconds and times it by 2. You could count for 5 seconds and times it, what would that be? That'd be times 6, right? Anyway, it's just that it's important in your policy that everyone does it the same way. So if you yelled out the number 12, everybody knows how much to times it by, right? So you don't want to have one nurse doing it one way, a doctor doing it another way, another nurse doing it another way. So if you all want to agree on, like, we're going to do 10 seconds times 6, whatever you want to do. So that's the important thing, is that it be consistent at your facility. In our education, we chose to go with the 6 times 10. And sometimes when I'm like practicing, I'm like, I don't know, maybe it'd be better if I counted a little longer, maybe 30 times 2 would be easier. So but you can see how you just track those and then you look across over time. What about variability and variation? You cannot you can tell whether heart rate increases. You can look at baseline rate. You can look at rhythm. Is it regular, irregular, increases or decreases? But you cannot determine variability. So if you're hearing decelerations, if you've seen meconium, if you're seeing any other anything else going on with the mother, that you feel like it's important to get a tracing or check back in with the continuous electronic fetal monitor to check variability, that is always an option for you. I would just not rely on that too often. I was talking to someone the other day, and they were talking about how actually we did a Ask the Expert panel for A1 the other day on the webinar, and they were saying that they were at their facility, they 20 minutes off, 20 minutes on. I mean, it's nothing horrible about that, but that just kind of defeats all of the trusting yourself. And also, where did that 20 minutes on and off come from? That's just made up. Like, there's no evidence to support that. So I would just say, just stay with IA. If you assess the patient's eligible for IA, you stay with IA unless you have some kind of clinical reason to shift to continuous electronic fetal monitoring. If you put them on continuous electronic fetal monitoring, and everything looks fine after 20 minutes, then you can go back to IA. It's going back to saying, do they remain eligible for IA? And again, I already talked a little bit about this, the maternal pulse using pulse oximetry. If you are wanting to check oxygenation of the mother, that's another reason to use pulse oximetry, not just to track maternal pulse rates. So let's talk about how to improve the safety of intermittent auscultation. And I'm going to go through, because that's really important component. If you add some new technology, and I would consider this a new skill, or it's a different type of technology that many RNs and physicians have not had a lot of practice in. You want to do it in a very thoughtful way. You want to start with your most low risk patient population. And in this case, feel free to go back to continuous electronic fetal monitoring when as you're learning. So kind of just helping yourself feel comfortable. If you take our course, the online course, you'll see that there is a practice guide, and this practice guide goes through how to interpret the and managing the IA results. And I think this you can if you take the course, you can download this, print this out, and have this accessible to you. You cannot determine category 3 with IA. You can only and some people will argue whether you can even technically, if you're really assessing, because you don't have variability, whether you want to call it category 2 or not. So just know that that's a controversy, but we decided to make it clear, like you could do baseline rhythm, accelerations, decelerations. Almost 80% of births fit in the category 2. So automatically being in category 2 does not mean that that person could not get IA, but some patients in category 2, I would put them back on the continuous electronic monitor. You also then want to have a flow sheet to follow. And then this is just an example. And we're updating this to have a column for maternal pulse. Not that you would take the maternal pulse every time, but it's just nice to have a way to be able to visually see it pulled out. And you can see like deceleration audible during last 20 seconds of contraction with return to baseline before end of contraction. Maternal position change from supine to standing will reassess in 5 minutes. So the essentials, and I've mentioned the policy and procedure quite a couple of times already today. You want to look at eligibility, frequency, documentation criteria, practice guides. What are your practice guides? Chain of communication, and then any of your management recommendations. You want education for assessing competency, periodic reviews of clinical performance. This is where you would have mentors. You would have people that are mentoring you, supporting you. If you're the person introducing it and you have nobody at your facility that has a lot of skills in this, I think taking a very simulation-based education, which is what we offer in our course. We offer 5 simulations, which give you some practice, not on a live patient. So that gets you prepared to be able to perform this on actual patients. So and then then working with each other and having more practice sessions and having extra, just like any new skill, the more you do it, the better, more proficient you become at it. You also want to, as with all labor outcomes, you want to track how the outcomes were and identify opportunities for improvement. But keep in mind, you're going to have bad outcomes for IA, and you're going to have bad outcomes for continuous electronic fetal monitoring. We have not ever been able to get rid of bad outcomes, regardless of using almost 100% continuous electronic fetal monitoring. So don't hold IA to an even bigger standard, because these outcomes will happen in either scenario. But I will tell you, it's so funny, like people are like, well, what about the legal team and what about the legal implications? Well, I was a director of nursing of two labor rooms and also in 2 separate hospitals. One of the labor rooms had a birthing center one of the hospitals had a birthing center 1 floor below the traditional LDR, high risk center, and also where also other low risk labors occurred. But in the birthing center, it was strict criteria, no epidurals, and was all very strict low risk patients. And only IA was performed in this birthing center after their baseline strip had been taken. Well, we had, some things happened in both locations. And I have to say, the hours and hours and hours of tracings that happen often, and experts over interpreting, like, why didn't the team they should have done the C-section here. You've all heard that. Like right here, this is like when the baby would have been, showed that it was time to deliver. Well, honestly, it was easier to defend the IA case because we didn't have all the overinterpretation, and the nurse had clear documentation. She had done the assessments on the appropriate intervals, and so so if the rationale is a legal argument, that doesn't, that isn't a very strong argument, in my opinion. It's our wanting something to be better than it is. We really, really want continuous electronic fetal monitoring to prevent bad outcomes, and it doesn't. And so, IA is easy to defend because it's evidence-based approach to care, and it provides very effective ways to assess the baby. Again, you want different ways of learning. IA, simulation-based learning, in-person education courses, online simulation courses, simulation labs, in situ real-time learning with a mentor is also. So I think it's not one or none. It's like a combination, I think, is ideal. Now, I am going to see if I can let's see if there's enough time. Dawn, is there enough time for us to see if we can do this practice?
About 10 minutes.
Okay. Do you want to do, then people may have Q&A, so maybe we first just see if people have any questions that they want answered before, and then if there's time, we can practice this simulation. How does that sound?
Sounds good.
All right. So let's open it up for questions, because I've gone through a lot of information really very quickly. What's your concerns? What are your thoughts? And those in the room with Dawn, you can go up to the mic and then I can hear you.
Let's see, and you can use the mic at their table too. So.
Oh, they have mics at their table. Oh, wow, that's cool.
So Deborah, how have hospitals approached trying to get, their staff, their nurses, trained in IA? And then how do they start with just policy and procedure? Or, I mean, sometimes when I think about the last time I looked at different policy on monitoring, a lot of times it's not even mentioned, that you can do. So just kind of wondering, like, what's a starting point for a hospital that maybe would like to look at how they could offer this to their low-risk patients?
Yeah, I think the first place to begin is to find the nurses and the doctors that are willing to try, like be kind of the early adopters for that setting. And then that group come up with some policy and procedure that of when they would try this, but and also how they prepare themselves educationally. I know that, and I have a quote later in the presentation, but I know that the midwives getting educated from Frontier, they made it a standard that before the midwives can go out and practice as students, that they needed to at a minimum complete the IA modules that we have, that because there's those 5 simulations, and you can't the course in order to pass the course, you have to get 100% on all of our knowledge checks in that. So it is a really good way to establish some basic educational standards and also have some practice in a safe setting. So I think simulation labs are really helpful. So getting some agreements and policies in place, making who's eligible, when they're going to, and like all of those things I just went over with all of you should be in the policy, how you're going to document and all of that. And then who will go back on? What are the situations where you're going to go back on to continuous electronic fetal monitoring? And then, so a minimum is policy and procedure and education. I would do both of those things, but start with the people who are really interested in freedom of movement. And I would also think about like situations like, okay, they're having spinning babies, having nurses that are learning that. I would pair those clinicians up with learning IA skills as well. So that's where I would start. Has anyone started? Has anyone done this at your hospitals? Anything you want to add? Will this be new to all your hospitals in Arkansas once you try it? This is where being remote is hard. So is Donna this new to all the hospitals then?
I think we all have we have a policy as well.
Okay. And so your hospital, you have a policy? Have you been practicing IA?
We have a policy in place, but we have a very low volume of patients who would even qualify for this. So I think the problem for us more so is the lack of ability for anyone to really become proficient at this, because most of our patients are inductions, they're on Pitocin the entire time. And so I feel like that's more where our gap is.
Is that the patient we've kind of made, like if they're being induced, that's not the patient you want to start with IA on, right? So, but you could still have, you can still have some practice around that, maybe not rely on it as on its own, but people could still be checking themselves or practicing that skill, even if you're using continuous electronic fetal monitoring, if they're not really, it's a way to practice is what I'm saying, the skill, so that people could start to become proficient, not relying on it at that point, but just starting to practice the skill itself, of how you listen and how you count. And and also then I'm just,
Check yourself as well,
yeah. So go ahead, say that. I couldn't hear you.
We cannot figure out how to turn off our mic, so there. But I do have a question. Why is your recommendation when you're doing IA to use a Doppler for the IA piece of it, as opposed to just using your EFM and turning it on and using it? Because I feel, at least with the EFM, are my thoughts, so please educate me, is at least with the EFM, you have a tracing that shows up there, so you can at least show that you've done the IA.
Yeah, so that's was what I read was his A1's recommendation. That was the quote from A1, that because it's such a short tracing. You don't want to have these little snippets of tracing. You actually want to, just like we have people take pulse without having it like on a cardiac monitor, right? So we don't have to have a cardiac monitor on every person to record a heart rate. And so it's the same principle. So you don't want, not every patient who's admitted to the hospital needs telemetry, right? So what we've done is we've applied essentially telemetry to every fetus, which isn't needed. And so a nurse is just trusted to do the assessment and write the numbers down. And you don't really want it. It can be, once it's entered into the record, this small little tracing, it can be overinterpreted by others, and it's not helpful. It's just be like not even doing a full EKG, but you've got this little trace. It doesn't make any sense to do it that way. And that's the reason. That's one reason. The other reason is, and this is just my reason, so is that it doesn't, if you have the handheld, you can go wherever the patient is, right? So you don't have them have to be back in the room and with this big monitor either. So it's better not to have equipment that's recording something, and just have the nurse do this heart rate and record it in their record like they would if they took a pulse and a respiratory rate. It's just how it just makes it easier for you to not have those little snippets. There's no reason to save them, and and there could be detriments to having a bunch of little snippets for you legally. Does that make sense? And others may have other reasons, but I can go back to that slide from A1, but that was their reason why they recommended it not be on using those electronic monitors. That's not what they were designed for, so that's the other reason. So yeah, anyone else have any other questions for me? I know we just have a couple more minutes, so I'll go through a few more slides. If there's any other question, feel free to email me later. But just wanted you to know that we do have data on those over 3,000 learners, almost 4,000 learners, saying that that the education did improve their skills, and they felt more ready to perform IA by completing that course. And again, we don't know when there's going to be a disaster. Like if we wait for a disaster to get the skill for IA, that's not going to be great. Hopefully power outages won't last too long, that our generators couldn't handle them, but there's hurricanes, there's all kinds of things that can happen. And we should be able, as labor room clinicians, be able to take care of patients with very, very few things, secondhand watch. And also I will say that I'm always surprised how high risk everybody's population is, because data tell us that 80% of population should be low risk. So if we have more than 80% of your population is high risk, then I worry that maybe there's some overdiagnosis going on, or some things happening that are leading to more high risk patients. So I would look at how you define high risk too, and moderate risk. So I do worry about why I have the question of, why is your population so high risk? And somebody's brought up before, well, what about obese patients? Well, it's actually easier to do intermittent auscultation on obese patients than it is continuous. But there is some education that you need to provide patients and let them understand why you're doing intermittent and how safe it is. And so, so I'm at my time, and anyone coming to the A1 convention, we're going to be have a whole group of people who have been using IA, as well as myself and Renee will be talking about IA there, but also others who have implemented IA. We're also doing a read between the lines on integration of IA into clinical practice. That will be on May 15th for an A1 webinar. So I definitely am excited that you all invited me to come and talk about this important skill and this important topic. And you all are a cutting edge there in Arkansas, like leading the country and helping get this done. There are other states like Michigan and other places that have also implemented IA initiatives related to their C-section work. So yeah, anyway, thank you so much for your time today.